Uh, Good morning, everyone. I'll be presenting anatomical variation in pulmonary fissures and CT. This will be a journal-based presentation based on a journal from Moise et al. Basically, a surgeon from Sweden. The article is carried out in Pakistan. It was published in Curious Journal of Medical Science in 2022, in volume 14, issue 11. The introduction section describes well about the lung anatomy and the fissures. The lung lobes is divided by interlobar fissures, that is oblique and horizontal in the right side and oblique only in the left side. In the variations arise from the embryologic development itself. Incomplete or absent fissures are due to the incomplete pleural dissolution during the development phase, and the accessory fissures are because of when spaces between bronchopulmonary buds fail to disappear. These are important for interpretation of CT scan, surgical planning, especially in lobectomy, segmentectomy, avoiding and for avoiding diagnostic pitfalls as well. As you know, these fissures, they are the pleural indentation. They consist of the two visceral pleura indented inside, and on the base of this fissure, there is always a pulmonary artery that we can isolate. So in the picture right side, this is the normal anatomy, normal fissures. Right side, we have oblique and horizontal fissures, giving the three lobes, and in left side, we have only one oblique fissure giving two lobe system. But there can be accessory fissures like superior and inferior accessory, azygous fissure, or left horizontal fissure. We'll discuss that as we go on to the next slides. The main function of these fissures are it allows the stress-free movement of the lobes during expiration. So it is said that if some patient has a fused fissure and they have the lung pathology, they will experience hypoxia earlier than the patient who have fully developed fissure. And it also ensures uniform expansion of lobes and segments. So there can be some uncommon accessory fissures like accessory fissure between medial and lateral segment of the right middle lobe, accessory fissure between superior and inferior segment of the lingula on the left lung, and accessory fissure between the anterior basal and lateral basal segment of the left lobe on both sides, and presence of left horizontal fissure, giving to the impression of the third lobe of the left lobe. So these are the fissure, the azygous fissure that develops usually when the azygous vein pierces deep to the apical lobe of the right lobe, and the pleural visceral pleura indents with the azygous vein, and the different lobes, azygous lobe is given out. This is the azygous fissure. Another is the right horizontal fissure. Right superior, this is the normal fissure. Right superior accessory fissure. It separates the apical lobe with other lobe. These are incomplete fissure. Right inferior accessory fissure which separates the seven from other lobes. It's also incomplete fissure. Then left minor fissure, left superior accessory fissure, and left inferior accessory fissure. These can be some uncommon accessory fissures shown in a schematic diagram. So the rationale of this study was there are variations in pattern of lobar collapse, spread of infection, and CT interpretation and surgical outcomes as well. And also there were limited data from the South Asian population, especially Pakistan. So this study was conducted in Pakistan itself. Hence the study, it aims to determine the frequency of anatomical variations in pulmonary fissures of CT scan, on CT scan. So it's done in a tertiary care hospital in Karachi, Pakistan. And it included, it is a cross-sectional observational study for a duration of 6 months in a department of radiology, Karachi, and they did non-probability consecutive sampling in a 384 patients. So all the patients with age more than 15 years were included, and HRCT just without major pathology were included in study. And exclusion criteria was significant airspace interstitial disease were excluded, long masses, pleural disease, prior surgery affecting the fissures were excluded. And the 16 slice Toshiba machine were used for HRCT with ampere and long window creation in 120 kilovolt, 200 milliampere, and 0.8 slice interval of the CT scan in full in inspiration breathhold phase, and it was interpreted by two expert radiologists. So the operational definition and the pictures shown in the article was the superior accessory fissure that was between the superior and basal segment of the lower lobe. So we can see the indented fissure. So it separates the basal lobe and then superior apical lobe of the lower lobe. So this was a complete superior accessory fissure in the guess. So this was representative units that was kept in the article. And another is inferior accessory fissure, which separates the medial basal segment from the rest of the lower lobe, as shown in the schematic diagram before. So this is the inferior accessory fissure, which separates the segment 7 with the rest of the basal lobe at 9, 10. And also azygous fissure, as I said, when the azygous vein penetrates the right upper lobe and drags the pleura along it, creating a distinct accessory fissure and a distinct lobe sometimes. So this was a typical azygous fissure with the separate azygous, complete azygous fissure as shown in the diagram in the article. So they did it in 382 patients, and 218 of them were males, 164 of them were females. So if we see the absence of, the absence of normal fissure, absent right horizontal fissure was seen in up to 2%, 10 patients. Other were right oblique fissure absent were not seen, absent left oblique fissure were not seen. Just minor fissure in the right side were absent in 2.6%. So overall, the azygous fissure was seen in 14 patients, that is 3.7%. Superior accessory fissure was seen in right and left both was seen in 6 people or 1.6%, and then inferior accessory fissure in 1%, left horizontal fissure in 1%, the other were 0. So the azygous fissure, as said, the left horizontal fissure was 0.9%. The significant distribution was seen among the male and female in superior accessory fissure, as shown in the article. So, if as per the discussion of the article, there was 7.33% fissural variation in the current study, while other studies showed similar or more number of the fissure variation as per the sample size. Uh, Suppose the Manjunath et al., they had 22.9% fissure variation, and then Ranavira et al. From India had 68% fissure variation. And subsequently, other studies as 52, 5, and 63, up to 83.4% of the right complete oblique fissure and 16.6% of right incomplete oblique fissures were seen in different literatures. And if we see the gender correlation, there is higher incidence in males, similar to Manjunath et al. Study, and maybe it may be influenced by environmental and genetic factors. And looking at the clinical implication as given by the authors, these variations can alter the pattern of lobar collapse, infection spread, tumor localization, or even the symptoms experienced by the patients. So these awareness helps radiologists in accurate diagnosis and surgeons in safe operative planning. As this base of this fissure, there is always a pulmonary artery, as I said. The overall Relevance being the fissural anatomy understanding prevents the diagnostic error, interpreting complications, and improves the surgical outcome. Definitely, if the fissure is complete, then the identification of artery becomes easier and the dissection in the fissures become easier, and there is a lesser ear leak. If the fissures is incomplete, then we may have to inadvertently dissect in the wrong plane, which may lead to the ear leak, more ear leak. So that is always there. And the limitation of this study, as accepted by the authors, was it was a single center study. For a observational demographic study like this, the sample size is very lesser, and only SRCT is being used, no 3D reconstruction correlation, which would have been more beneficial for the diagnosis of the fissures. And it definitely needs large multicentral validation. And if I have to add some more, they have not classified the incomplete fissure, as there is always there is a classification of the incomplete fissures explained in various literature. So they could have added that. And to conclude, the SL fissures in this article was 7.33% of the subjects, and awareness of the fissural variations is crucial for radiologists and surgeons both. Thank you.
No, sir. Okay, so thank you. हामीले चाहिँ यसको रेलिभेन्स चाहिँ केमा देख्छौँ भने चिया मगाइदिउँ न तिन चारवटा मगाइदिउँ
मैले यो सरलाई दिन्छु
चिया खान्छ चिया लिउँ न अलिअलि यसको रिलेभेन्स मैले के देख्छु भने मैले पहिला स्टडी गर्न खोजेको थिएँ वेदर सच स्टडिज ह्याभ बिन डन इन नट अनि एउटा पार्टबाट स्टडी भएर चाहिँ उनीहरूले क्याडाबरमा गएर चाहिँ एनाटोमी डिपार्टमेन्ट अफ एनाटोमीले अनि उनीहरू डिपार्टमेन्ट अफ एनाटोमीमा सब लङ्स चाहिँ 50 क्याडाबरी कति ल्याएर कि 32 not too many 30 to 50 lungs were taken and they studied macroscopically whether they are accessory fissures or not, complete fissure, incomplete fissure. This is also a good thing किनभने उनीहरूले फर्स्ट study as such was done from Nepal also. इन्डियाबाट जुन ससाङको मेन्टर थियो एक्सटर्न लगाएको थियो मञ्जुनाथ उनले कोट गरेको थियो in their literature they have said 22% of the anatomical fissural variation, so it's too big, too much मलाई जहाँसम्म लाग्छ, maybe because they have done a good quality CT scan, so they detected the higher range of their prevalence of such people that they had got the anatomical variations. In this particular study there was 7.2% approximately. So it means the anatomical variations in the fissures do exist and it is of some importance. मैले आज यो टपिकको रिलेमा सर्च गर्दै थिएँ कि के टपिक आज मलाई प्रेजेन्ट गर्ने, मेरो के मकसद थियो भने हामीलाई सर्जन हुँदाखेरि यदि फिसर कम्प्लिट छ भने हामी सर्जरी इजी हुन्छ, because as he said that it will be very open like book, so we can find the artery well. It is less tedious for the dissection. Also we can staple or whatever we do, the air leakage in the posterior period is less, there are less chances of error. But things are not quite good here in our country, that because of various factors the fissures are not open. You don't find the fissures quite often, the fused fissures are there. So how you are going to predict there is the fusion of the fissures pre-operatively? So one of them is the CT scan. We don't have the 3D reconstruction, so we cannot exactly say that definitely this fissure is fused or not, but we can predict. So there is a grading that he mentioned that should have been included in this article, the Craig and Walker उनीहरू classification systems, they classify 0 means there is completely like book open fissure. So totally when you do VATS or do the open, the artery is naked and the fissures are complete. Like quite often what happens in the left lower lobe and upper lobe are quite open, so you can easily find it out. So that is the 0, it means there is no reason, no fusion of the fissures, it's straightforward and easy. So that's why it means for surgery also, if you are doing the lobectomy or whatever, it's very quite convenient, easy. You can find out the artery once everything is very clear. Sometimes what happens, artery is visualized, but the fissure at some point is fused, not completely open fissure. It means you are visualizing the artery at some point without the fusion. हुन्छ नि कतिपय समयमा देख्छु कि त्यो आर्टरी देखिरहेछ फिसरमा, but कता कता एडिसन fusion पनि छ. That is first stage according to the first degree of the fusion of the fissure. Second degree means when fissure is there but you don't visualize. Fissure देखिन्छ, but you don't see the artery. Then the next degree will be that you totally absent fissure. You don't see the fissure कहाँ छ. Quite often के हुन्छ भने middle lobe or upper lobe मा हेर्दाखेरि generally we have the partial fissure of the fissure. Always in 80% of the cases, the interior portion of the horizontal fissure is fused. तर quite often middle र upper lobe मा fissure ही देखिँदैन. So that's according to him. So this kind of the fusion of fissures can be predicted pre-operatively. त्यही भएर मेरो vision के थियो यसबाट आउटबाट दुईटा थियो मकसद. एउटा चाहिँ so in our study it's very simple study. हामीले सबै CT scan जुन लिन्छौँ हामी एउटा सफ्टवेयर बनाएर स्टडी गरौँ कि सिम्पल चिज चाहिँ हामी पनि हाई रेजोल्युसन गर्छौँ. उनीहरूले 0.8 mm को कोलिमेसन गरेर चाहिँ हामी 1 mm कोलिमेसन द्याट्स पोसिबल हियर. So in general, normal thickness of the fissure is 1 to 1.5 mm. So if you do something less than 1 mm, we can detect the fissure well. So this much हामी त गर्न सक्छौँ, predict गर्न सक्छौँ. Then we take the patient for surgery. Then we identify really it is validated by the macroscopic observation during surgery. So एउटा यो vision was. Second, we don't know exactly in our Nepalese population what is the prevalence of accessories fissure that have been described, right? Azygous fissure छ कि छैन जुन हामीले एउटा कागजको गरेको थियो त्यसमा that was not the azygous fissure, but that may happen. Azygous fissure छ भने superior accessory fissure छ भने left lobe मा minor fissure छ etc. that was described in the article. त्यो पनि मलाई लाग्छ कि यो स्टडी भित्र त्यो पनि पार्न सकिन्छ. सिम्पल बेसिक स्टडी that we can do. मेन चाहिँ हामीले प्रियबाट अर्को कुरो चाहिँ मलाई लाग्छ यो आर्टिकलमा उनीहरूले oncological aspect केही राख्न खोजे चाहिँ पुरै राखेको छैन. किन one of the Japanese classifications that say that tumor spread is depending, tumor staging also depends upon whether the visceral pleura is invaded or not. So fissure is the fusion of the two layers of the visceral pleura, like in the peritoneal cavity, right? This the fusion of visceral pleura as a two layer of fissure forms. So in one way, that fissure prevents the spread of the tumor from one lobe to another lobe. So it is crossed by if there is no fissure, then it's very easy for the tumor to cross to the adjacent lobe. Right? So that will upstage the tumor. The T2 they cross the lobe according to the size, or maybe the lymphatic pattern may be different. Hold infection, infection hold fissure tumor spread hold. Those according to the Japanese classification, pleural invasion is PL0 when pleural invasion. जस्तो हामीले pleural invasion राख्छौं हाम्रो NCC UICC classification simple छ. Visceral invasion present, visceral invasion absent. Parietal pleural invasion present, pleural invasion absent. Visceral pleural invasion means T2, parietal pleural invasion means T3. Japanese legal they have further classified. Pleural PL0 means there is no pleural invasion. PL1 it means there is the invasion into the visceral pleura, but the external elastic layer is invaded. PL2 means it is invaded to the parietal pleura. So उनीहरु classification यस्तो चाहिँ void doesn't. So यिनीहरुको चाहिँ यिनीहरु के छ आधी बाँड्नु यसमा सबैलाई खाम. So यो चाहिँ डिपेन्ड गर्छ त्यो सिनेरियो. So ओन्कोलोजिकल पनि यसको मिनिङ चाहिँ छ. मोर मिनिङफुल कहिले हुन्छ कि जब हामी फिसर देख्दैनौँ फिसर भने देयर आर टु वेज अफ सर्जरी. वान इज द फिसरलेस टेक्निक, अदर इज द फिसर बेस्ड टेक्निक. त्यही भएर जसमा फिसर हुँदैन त्यसमा एउटा लजिकल एप्रोच के भन्छ, यु एप्रोच द फिसर लास्टली फिसरलेस. यु डिभाइड द आर्टरी, डिभाइड द भेन, डिभाइड द ब्रोंकस, देन द फिसर एनाटोमिकली डु फिसरलेस. यु डोन्ट ट्राई टु dissect the fissure. त्यही भएर एयर लिकेज कम हुन्छ, अननेसेसरी उजिङ ब्लिडिङ पनि कम हुन्छ. सो यो इम्पोर्टेन्स यो टपिकको मैले देख्दाखेरि यही देख्छु कि हाम्रो सिनेरियो एउटा हामीले प्रिभलेन्स थाहा छैन. हाउ क्यान वी प्रिडिक्ट प्री अपरेटिभ द्याट डेफिनेटली वी आर ल्यान्डिङ अपन अ बिगर प्रब्लम द्याट वी निड मोर मेटिकुलस डाइसेक्सन ड्युरिङ द सर्जरी. Thirdly, if it is a case of malignancy, so definitely there will be incontinuity spread to the adjacent lobe or not. And lastly, whether you are trying to do the fissure-based technique or fissure-less technique. And so on the other hand, you will study how to do the perform the fissure-less technique. So as a question, मलाई लाग्छ यो लजिकली हो, जानेको राम्रै हो. केही छ कमेन्ट तिमीहरुको भन. सिम्पल लाग्छ मलाई होइन यो पोसिबल छ गर्न पनि मिल्छ तिमीलाई केही क्वेसन छ भने
मलाई क्वेसन त एक दुईवटा मैले सिकेको हेरेको छ त यो आर्टिकल पछि गएर अनि म एसेसरी लोड यही हो कि होइन भनेर ठ्याक्क कहिलेकाहीँ त्यो थिक सेप्टाहरू एल्भेल इन्टरएल्भेलर सेप्टा हो कि अनि फाइबरटिक ब्यान्ड हो कि अलिक झुक्किन कहिलेकाहीँ फेरि भिसरल इन्डेन्टेसन पनि देखिन्छ मैले एक दुईवटामा हजुरलाई देखाउँछु अहिले
यो एजाइगस फिसर हाम्रो यहाँ पनि कमन हुनुपर्ने सिटीमा हामीले धेरै देख्छौँ कि हामी देख्छौँ कति पर्सेन्ट हामीले डकुमेन्ट गरेका छैन यो सिम्पल स्टडी हुनसक्छ डकुमेन्ट गर्न